The ankle joint consists of two joint partners, the upper ankle joint and the lower ankle joint. The best way to explain it is with a model. Only the bones are shown here. We imagine the ligamentous apparatus visually. The outer ligament complex consists of three ligaments, and I will go into more detail about the inner ligament complex in a moment. Regarding the bones, we have several structures. We have on the one hand the talus bone, which is surrounded by the malleolar fork, i.e. the lower part of the fibula and the lower part of the tibia. Both articulated partners, distal tibia and fibula, could drift apart along the talus. And that's why we have a ligament, a syndesmosis, which surrounds the bones in front and behind and prevents them from sliding apart. The lower ankle joint connects to it, and the possibilities of ankle movement are, on the one hand, extension and flexion, i.e. bending and stretching, and on the other hand, pro and supination. This supination trauma is the classic injury trauma which can arise from sports injuries. Ligaments that can be injured in the process are the three outer ligaments, and you can imagine them as fan-shaped from front to back. There are also three parts from front to back on the inside, also called deltoid ligament, and finally there is the syndesmosis. If we look at where ankle sprains can happen, we always think of sports accidents, i.e. in football, basketball, handball, where you have this twisting trauma in your ankle, either with or without the opponent's influence in this torsion. That means, for example, to land on the foot of the opponent and thus cause supination trauma. But also in everyday conditions, ankle sprains quite commonly happen due to banal causes, such as falling downstairs or even while jogging in the woods, or when rushing to the train station in the morning and you stumble over the curb. The typical trauma is the supination trauma, where one rolls over the outer edge of the foot and then this twisting mechanism occurs, which is, of course, very painful in the first place and also leads to swelling and bruising. Most ankle injuries affect the external ligament apparatus. This is not always a rupture, but can also be a grade 1 distortion, i.e. mild ligament sprain. And the greater the impact of the force, due to the effects of the opponent or also by the weight of the patient or simply by the force of the impact, the bigger the accompanying injury can be. But not only the external apparatus can be affected. If there is, for example, a certain rotational movement, then the back wall apparatus or syndesmosis can be involved. Or, in the worst case, there can be associated fractures. Like with all examinations, it is recommended to follow a standard scheme, which you always repeat so that you do not overlook anything. In the first instance, case history is crucial. If I know the patient has played basketball, then I first ask whether it happened with or without the influence of opponents, or whether there has ever been a previous injury where the ankle joint was involved, etc. Then the next thing is the inspection. It is crucial to pay attention to the swelling and the typical hematoma. This is usually lateral, and because the blood sinks down and cannot run further down, you can see a stripe which also shows the severity of the injury. Then next, whether there are painful pressure points. For example, the tip of the fibula, or pain at the inner tip, or when exerting pressure on the syndesmosis. Then there is the supination stress test, where I'm trying to emulate the mechanism of injury. That means I trigger the supination again, which can be painful in many cases. Here too, of course, the premise is that the more pain the patient is in, the less pronounced the examination will of course be. Another nice test is the forward movement of the talus. This also gives me an indication about whether or not there is ligament instability, because when all outer ligaments are torn, then usually there is a clearly relevant forward movement of the talus. The decisive factor here would be that you also do it in a side comparison, because there are always athletes who have hyperlaxic ligaments and the ligaments can be looser. The syndesmosis can be checked by doing a test like this. You put pressure on the tibia and fibula within the malleolar fork, and this can then lead to pressure pain, which makes a statement about the condition of the syndesmosis. If I suspect that something serious could be damaged, then I move on to imaging. In the case of clear painfulness, and with the inability to walk more than 3 steps without pain, the X-ray makes sense firstly in 2 planes, and then in the further course you can add layered image diagnostics with the MRI. First and foremost, this is the domain of conservative therapy. Only in exceptional cases, which I'll talk about later, operative treatment can also be considered. Therapy is also divided into several stages. The acute phase, i.e. directly on the sidelines or after falling down the stairs at home. Treatment is mostly according to the RICE scheme. That means you have a rest, you use ice for cooling, compression and elevation. It's a good idea to have cold pads in stock, for example in the refrigerator, at home, or at the edge of the pitch or somewhere cool, which you can then place on the ankle joint around the malleolar fork where it hurts. Most ankle injuries can be well managed this way, and after 1 to 3 days, the patients are usually pain-free again. If the complaints persist, the family doctor is usually consulted, and of course in acute cases, the emergency room in the hospital, or the resident orthopaedist or trauma surgeon. After the diagnostics that I just explained, we will decide on which therapy we can recommend to the patient. It has been proven that one can load in a way that is adapted to the pain, with the ankle joint in a brace or, in serious cases, in a walker. If you suspect that more than the ligament apparatus, i.e. outer ligament or inner ligament apparatus, is broken and the syndesmosis could be affected, a walker can be applied, which ensures that the range of movement in the ankle joint is almost eliminated, and the ankle joint can rest better. In the further course, or in the case of less serious injuries, you can also resort to an orthosis. The modular concept has been established in recent years, which means you can adapt the orthosis depending on the phase of the injury. This means in the first phase, when I still have pain, swelling, and above all, limited mobility, then the most rigid orthosis possible would still be needed. If it then goes to the second phase afterwards, the reality is significantly improved, the patients can walk without pain, they can then adapt the orthosis bit by bit, which means you can give less stability. In the third phase, when it comes to slowly regaining everyday fitness and also the ability to play sports, you only need a little support. Ankle braces work in such a way that they try to support the natural healing phases of the body. So you want the ligaments and structures of the ankle to heal without being exposed to any re-trauma or risk factors. In the first phase, it is important to reduce the swelling, which is quite possible with the orthosis by incorporating a material that increases the compression so that the swelling can be reduced. If you want to prevent twisting in the acute phase, it makes sense to have a supination protection. That can be achieved with a strap, for example, that you pull over the orthosis, which immediately limits forward movement of the talus. When the mobility is better and the stability has also improved accordingly, then you can still remove the lateral stay, which is also the purpose of the modular system. Another advantage of these orthoses is that they can also be worn in shoes. Whether or not you put a sock under the orthosis is up to you, but it is usually the case that most patients wear a sock under their orthosis. Of course, it is also important that in the acute phase, the orthosis can be removed without any problems for body hygiene, but it should also be worn at night to further reduce the swelling and so the ankle doesn't regain swelling overnight. The orthosis is of course only as good as it is worn, so the best orthosis is of no use if the patients do not accept it because it is uncomfortable, for example in shoes. Worth noting in this regard is that the full stability and the best functioning of the orthosis is only achieved if it is actually worn in the shoe, and not flip-flops or sandals, but in normal stable shoes. That's a very interesting question, because in the last few years there has also been a paradigm shift. The last few years are now probably already 20 years ago, but in the past it was the case that every ligament lesion on the ankle was treated acutely. However, it's been shown that the results have become comparably good or bad with or without surgery, which means that, despite surgical treatment in the acute phase, we had a very high proportion of patients at the time who had poor results. Meanwhile, there are few reasons that force us directly to the operation. First and foremost, these are mostly fractures. In case of lateral ankle fracture or ligament injury with inner ligament involvement, etc., which is something you can easily see on an X-ray, then surgery should be considered in most cases and also be recommended to patients. If, on the other hand, it is only a lesion of the lateral ligament apparatus, conservative therapy can clearly be preferred in the acute phase. Should the syndesmosis be involved, or if multi-ligament injuries are suspected, the MRI is certainly necessary to secure the diagnosis, and on the basis of which one can then determine whether one would have to stabilize the syndesmosis, for example. In the further course, the patient can also be required to have an operation after having started conservative therapy. If, for example, after 6 months they still have stress-related pains, which is then typically ventral, meaning in the anterior part of the joint, or in case of chronic mechanical instability which cannot be controlled even by physiotherapeutic applications. To illustrate the cases that should be treated surgically, and even already acutely, we brought an X-ray here with us, where you can clearly see the fracture of the fibula, which is located a little higher than the syndesmosis. And here there is involvement of the inner ligament, which then leads us to the operation indication. In this case, an osteosynthesis with plates. First and foremost, you can't make the aftercare the same for everyone. It's very individual, depending on the healing process, and we have to orient ourselves very much to the status of the patient. That is, if we have someone who still has a lot of swelling, we would like to reduce this swelling, and then we can gradually improve our movements, etc. If we have a good load capacity of the ankle joint, have regained good mobility, and also do not experience pain, then we can go on to add early functional training according to physiotherapeutic instructions. There are, for example, exercises that you can also do on your own at home. You can stabilize the outside of your foot against the wall, for example. You can regain the everyday ability to climb stairs. Here it is very good to use the handrail so that you put weight on the ankle in a controlled manner, and then gradually the function and normal mobility in everyday life can be restored. This is a burning question for many amateur athletes. It is usually the case that you can do endurance sports again after 4 to 6 weeks, such as light jogging, for example, while pivoting sports, that is, everything that is fun and involves a ball, can be resumed after 8 to 12 weeks, depending on the pain. What would certainly be a mistake is that one exercises with pain, or even worse, takes painkillers just to be able to practice the sport. This should not be done under any circumstances.